Before I start the topic that was given to me as intrapartum stillbirth, I would like to thank each one of you and my gratitude for the founders, Dr. Tankin and her team, Dr. Neelam Agarwal, for having given me this opportunity to be the vice president. It's indeed a privilege, and I look forward to working with all of you on this very important. This was an area which was very close to my heart for quite a lot of years. So over the next few minutes, I think I've been given 10 minutes, intrapartum stillbirth. By definition, it is a baby that was alive at the onset of labor, and then you have a stillbirth later, loses its life. India's stillbirth rate stands at around 13.9 in 2019, 40% intrapartum. But if we take a look at the developed countries and the developing countries, there's a huge difference in the proportion of intrapartum stillbirths. And that allows you to look at it with the scope that these are preventable, avoidable, if the resources can be there. Are there any risk factors? Are there any women who can be identified that this woman would be at risk factors? There are plenty, we all know them. We have worked with all of these risk factors. But if you evaluate each case, there is a series of delays that you find. And these delays are similar to those of maternal deaths. And if you want to correct these delays, you will have to start improving care in the hospitals, mobilization of community, and transport facilities as three main prongs, and then move forward. But one of the factors that's very important that all of us should remember whenever we are putting up a plan for prevention of stillbirths is the association of wealth and intrapartum stillbirths. You won't find rich and affluent people having a higher incidence, but you will have the poorest having the maximum risk. And this dose relationship for intrapartum stillbirths is absolutely heartbreaking sometimes, because those who have the least resources or the socioeconomic strata is very poor, they are the ones who suffer most. Are there any interventions that can reduce intrapartum stillbirths? There are plenty of interventions that have been studied, but most important is availability of cesarean section facilities. Those facilities which do not have the ability to do cesarean section, absent or inadequate, have a delayed obstetric care. And you will find that where the cesarean section is too less, you will find that intrapartum stillbirths are very high. This problem does not occur for developed countries, but only for developing countries, where this procedure or life-saving procedure there is a delay in care. The same thing holds for instrumental delivery or assisted birth. When the team is not trained, when there is reluctance to put up a vacuum or a forceps, and you find that either you have an asphyxiated baby at the end of the journey, or you may have a stillbirth. At this point of time, I would just like you to share our story of stillbirth reduction at Fernandez Hospital. We are a 300-bed single specialty obgyn and neonatology, and we do about 10,000 births annually. Our stillbirth rate has had a 40% reduction in the past 1 decade. Today, we stand at, for more than 28 weeks, we stand for 2.9 per thousand, and for more than 24 weeks, we stand for 4.2 per thousand for singleton booked population. Now, this is a journey that has been through the growth assessment protocol from Perinatal Institute, and with a parallel increase in SGA detection rates in antenatal care. But it's also very important for us to understand that the intrapartum stillbirths proportion is, we have on an average 1 in a year, that is 1 in 10,000, or max 2 in a year. And sometimes if we are lucky, we don't have any intrapartum stillbirth in a year, and that would be our target or achievement that would be there. Now, moving forward with this is how we have done the changes, and they are very simple. They are basically protocol-based and a kind of step ladder-based intervention. Do we have a risk assessment, risk category assessment at admission? How do we call a low-risk mother and a high-risk mother? So we have taken this from Malaysia and incorporated it as an electronic kind of a sheet. Without doing this sheet, you can't move forward, because a woman has to be classified as either high risk or low risk. Similarly, for SGA assessment or for fetal growth, we have taken this assessment pathway from the NICE guidelines, and also incorporated the stillbirth prevention care bundle. We have to look at all the elements that I mentioned over here and see whether all the elements are being carried out in its entirety in your hospital. The most important variable or failure of intrapartum fetal monitoring leads to intrapartum stillbirth. And what is very important for all of us to understand is the most important tool over here is not CTG, but intermittent auscultation. Majority of the women who are low risk, okay, have to be monitored with intermittent auscultation. And with proper training and proper application, we can identify fetal distress in the vast majority, where small proportion would require electronic fetal monitoring. The minute we say intermittent auscultation, everyone starts talking, saying we don't have staff, we can't do one-to-one monitoring. What we have done at Fernandez is we have used nursing aides and taught them very specific tasks and have an excellent support. So all the CTGs in the hospital are done by these people. We make it mandatory to have an fetal monitoring training and certification. In Fernandez, we have been using for the past decade K2MS certification for obstetric emergencies as well as fetal monitoring. Is your entire team certified for obstetric emergency care? Because this matters a lot when you're talking about every member of your team being capable and being a strong link in your chain. We don't want a weak person in the entire pathway, so that you will have a sudden collapse of your protocols. So any kind of certification is acceptable, whether it's from also or for K2MS, but you should have a certification. Oxytocin is the most dangerous drug for the baby on the labor ward, especially when the baby is in labor. Do we have an oxytocin bundle? Do we have indications for oxytocin use? What kind of an infusion regimen do you use? Do you use a high dose regimen or a low dose regimen? Do you have the concept of intrauterine resuscitation? This is important whenever you're using oxytocics. Do you have tocolytic on your labor ward? Do you have terbutaline? Do you have nitroglycerin? But create a kind of a crash cesarean section drill, which would be utilizing your own resources, your own setup, the people who are there manning the labor ward, as well as the theater, as well as neonatal intensive unit, so that your decision to delivery interval is on an average, okay, less than 30 minutes. At Fernandez Hospital, we are at 20 minutes for decision to delivery interval for a cord prolapse. Now, very important to remember that no cost interventions, these are the three ones, that is a companion in labor, hydration and nutrition, upright position, were the three most important interventions that were known to be associated with positive outcome. Midwives save lives, both women as well as the baby's lives. We started the midwifery training in 2011 as an in-house project. And today we have a big team. 80% of our low-risk mothers are delivered by the midwifery team, very capable and professional in their work. It's also very essential that we need to promote a culture of introspection. No blame. Every baby counts. Every baby has to be introspected. And then review our obstetric care system so that the next baby will not have an insult if there was an avoidable factor. I would like to conclude by saying fetal deaths in labor should be a quality indicator for obstetric care for every institution. It is possible to prevent intrapartum stillbirths. We need practical preventable solutions that can be applied to primary health center, to tertiary, secondary, any health center locally, nationally, and globally. And if we can all get together and work on it, I'm sure we will be able to avoid intrapartum stillbirths as a priority for the Stillbirth Society of India as a target. Thank you so much for giving me this time and opportunity.